fascia iliaca compartment block, often referred to as the fascia iliaca block. An overview. So the fascia iliaca block is a regional anaesthetic procedure. It provides a blockage to the femoral nerve, which exits the lumbar spine at levels of L2 to L4, and it runs predominantly down the anterior aspect of the thigh. We usually see a use of the fascia iliaca block in the context of a neck or femur fracture. I administer the block in A&E pretty much in every patient that might come in. Exceptions to this may be where a patient has a late presentation. We had a patient who had a fall 2 months prior and confirmed neck or femur fracture. They were of course confused, they weren't quite compos mentis, but there seemed to be no obvious clinical evidence of significant discomfort. As such, the purpose of the nerve block is to provide analgesia, pain relief. The procedure itself, the fascia iliaca itself, is on the anterior aspect of the thigh over the groin, and I'll go through the anatomy and those bony surface landmarks, how to actually access the area and where we administer the agent. So the question is, what agent? The anaesthetic agent used is levobupivacaine, and the levobupivacaine is 0.25%. The BNS suggests using a maximum dose of 2.5 milligrams per kilogram. The trust where I work, we generally go for 1.5 milligrams per kilogram as a max dose, purely perhaps on the back of safety issues. And again, I'll elaborate what safety in a few moments when we get there. As such, a 70 kilogram patient on average adult, and you can administer 1.5 times their body weight, i.e. 105 milligrams. The ampules that the levobupivacaine we have comes in 10 ml ampules, each ampule containing 25 milligrams. Therefore, in the 70 kg patient, we can use as many as 4 ampules, i.e. 40 milliliters. Levobupivacaine is a lipophilic agent, and the importance of that, again, I'll highlight in a few moments. It takes around about 30 minutes for the agent to actually take effect, and the effects of this last for us around about 8 hours, sometimes up to 10, give and take. There is a derivative of the same known as bupivacaine that takes a little bit, it works a little bit quicker, more around 10 minutes, the effect. However, the duration of the effect is around about 4 hours. Therefore, we prefer the levobupivacaine. Contraindications to the same. There are some absolute contraindications. Excuse me. This includes lack of consent rather. It includes infection at the local site over and around the groin or the thigh that might affect the site where we're going to inject. Any intolerance to anesthesia in the past of any sort, femoral artery bypass or a graft, and a relative contraindication is the use of anticoagulant therapy. Now, if you'll appreciate, I mentioned earlier that the general use of this is in the context of neck or femur fracture. Neck or femur fractures are rare in the younger population, much more common in the older population, and you will find a good proportion of those individuals of the over 60s population may well be on anticoagulant therapy of some sort for various reasons, including but not limited to atrial fibrillation. That's why we consider the use of anticoagulant therapy as a relative contraindication. The governance suggests in those situations that the procedure be carried out ultrasound guided. Personally, whether or not the patient is on anticoagulant therapy, I prefer to use the ultrasound guidance for my own assurance as well as that of the patient and patient safety. On the rare occasion I will use a blind procedure, and again, either way, the double pop procedure is used. Again, I'll explain in a few moments what exactly that is. Risks associated with the procedure. So as with any procedure where we are injecting, we will have the risk of infection. We'll have a risk of a little bit of discomfort and some perhaps ecchymosis in and around the area, a local rash or local allergy over the groin, and a failure of the procedure to work in the first place. The most important risk, however, is that of cardiotoxicity. Levobupivacaine is an extremely cardiotoxic agent. If introduced into the intravascular component or intravascular space, then we need to escalate the care for the patient immediately into a resus setting, and we need to consider immediate intervention with the antidote, which is intralipid at 20%. The intralipid is kept in resus settings. What we must do is administer a bolus of intralipid 20%, calculated at 1.5 milliliters per kilogram as a bolus, and then that should be followed up as an infusion at a rate of 0.25 milliliters per kilogram per minute. If, however, you find that the patient is the cardiotoxicity is still persistent, for example, the blood pressure has not come down, then you can administer another bolus. Or if you find that the patient is in asystole, then once again administer another agent. The intralipid is important, and this is why I mentioned earlier that levobupivacaine is a lipophilic agent. What it does is, in short, it binds to the intralipid that you just administered rather than being absorbed, and therefore reduces the effects of cardiotoxicity. That's in a nutshell how it works. Of course, not the pharmacological aspects. So let's now consider where exactly we are going to administer and what we're going to use in its entirety. So the equipment really is, you've got your levobupivacaine, the 4 ampules or 3 ampules, whichever. And I also use lidocaine to numb the surface area. So lidocaine, 10 mils, so 1% lidocaine, 10 mil insertion, usually 10 mils, can be a little bit less sometimes, depending on the size of the patient, of course. I'll administer that first over the site. It's all subcutaneous, both the lidocaine and the levobupivacaine, and followed by the actual anaesthetic. So equipment-wise, 10 mil syringe, drawing up needle, and a needle itself for the lidocaine, 50 mil syringe or a 30 mil syringe, depending on the quantity you're going to administer of the levobupivacaine, a drawing up needle, followed by a Tuhoy needle. A Tuhoy needle is a specialized needle. It's non-beveled, and it is actually radio opaque. Therefore, it is more easily visible on the ultrasound when you use this. Some people like to use an extension between the actual syringe and the Tuhoy needle. You may or may not want to do that. It's entirely up to you. It gives a little bit of flexibility. Personally, I use it and therefore employ a 2-man method instead of a single individual independent method. The idea is to clean the area. It's an aseptic technique. Use your ChloraPrep, clean the area, use ultrasound, locate where exactly you're going to administer, and I'll talk through that in a moment. Mark the area if you like, give it a good clean, get an ultrasound probe cover, get the ultrasound on. You've prepared all your agents, both the lidocaine and the levobupivacaine, sterile gloves, sterile apron, the full shebang, and administered lidocaine. Give it a few moments, check if it's gone numb, and then you go in with the levobupivacaine, administer the agent in its entirety, and follow up is very important. I usually, in fact not usually, I always advise the nurse or a member of the team to conduct a set of OBS at 5 minutes, 10 minutes, 15 minutes, 30 minutes, 45 minutes, and 60 minutes post-procedure. I appreciate different policies, different trusts. Many people may only do up to 15 minutes obs. Personally, I prefer to do up to an hour. So let's now talk about the bony landmarks and how do we locate the fascia iliaca compartment. As I suggested earlier, it's in the groin, so we have to consider the femoral triangle. Now, the femoral triangle, the borders at the superior end, you've got the inguinal ligament, that's the superior border. The lateral border is the sartorius muscle, and the medial border is the adductor longus muscle. The contents of the femoral triangle, going from lateral to medial, are the femoral nerve, femoral artery, femoral vein, an element of empty space followed by the lymphatics. This is the vertical lymphatic chain. The easy way to remember that is navel, lateral to medial, navel, NAV, that's the femoral NAV, and then the lymphatic, alpha lymphatic, E for the empty space. There is lateral to the femoral nerve, you have the pectineus muscle, and also just in and around the area you have the lateral femoral cutaneous nerve. That isn't usually of concern for the most part of it. How do you locate these landmarks then moving forward? You have to locate the ASIS, so the anterior superior iliac spine on the iliac crest, and you have to locate the pubic symphysis. When you go halfway between the ASIS and the pubic symphysis, halfway to that, that's known as the mid-inguinal point. At the mid-inguinal point, you find the femoral artery. This is not where we want to be. This is not where we want to be. You go from the ASIS to the pubic tubercle. Remember, the pubic symphysis. On either side, you've got the pubic tubercle. You go to the pubic tubercle, ASIS, and these are the sites of attachment for the inguinal ligament. Halfway to that, and you are immediately more lateral to the femoral artery, and halfway to that is what we call the midpoint of the inguinal ligament. You go 1 centimeter laterally, 1 centimeter below that midpoint of the inguinal ligament, and that's usually a safe site. That's one of the ways you can be a bit safer. The alternative method is to go middle finger on the ASIS, this middle finger on the pubic tubercle, and then use your first finger and you just extend those, and in doing so you'll separate the area into 3 equal sections, 1, 2 between the index fingers and 3. You will administer anywhere near this or in the lateral compartment. Okay, that's the area where you're going to administer, there or lateral to that, given that's lateral and this has medial. So lateral, medial, there you are, and anywhere here or this space over here. Important factors to consider when you are going in with the needle. You do not, and this is a common error that I see, you do not go from here, from lateral to medial, you do not go immediately, because by the time you've gone deep enough, you will actually go very close to the femoral artery and the femoral vein. Neither do you go superiorly, and again that's another common error. If a patient has a rather large visceraptosis, you move the viscera back, clear the area, and then you actually go forward with the needle, you inject the needle. The reason being, if you go superiorly or if you do not clear that viscera, then there's a chance that you may well perforate the viscera, which again is not what we want to be doing. All we do once we've located the area is we go directly, because the patient is laid supine of course, we're going to go directly downwards in an ever so slight medial direction, and I mean ever so slight. It's virtually straight down. When you go forward, when you actually proceed with the needle, you'll feel an initial pop. That initial one usually is a double pop, a very, very 2 clicks kind of together, and you've got to really feel and listen out for the 2 together, because they virtually feel like one. That's the overlying skin followed by the fascia lata. You then proceed deeper and you will go through a second pop, and that pop, sometimes audible but certainly more palpable, is a fascia iliaca. That's the point where we stop. That's the point where we administer. So you aspirate and then you administer the agent. There should be no resistance to the administration of the agent. If there is a resistance, you need to move the needle, and that's your fascia iliaca compartment. Ultrasound guided, you will be able to see the fascia lata, you will be able to see the fascia iliaca, and just deep to the fascia iliaca is the iliopsoas muscle or the iliacus. Lateral to that is the pectineus muscle, and you've also got the sartorius just on the other side. There's your locations, there are your bony landmarks, agent, what we use, why we use, how much we use. Remember, the neck of femur fracture, the classification doesn't matter. Yes, okay, we've got Gardner's classification, but it doesn't matter because we are not informing the surgical management and which prosthetic we use or whatever else. That's for the orthopedic team to consider and inform. The purpose of the block is analgesia and pain relief. As such, the exact classification of the femoral nerve and the neck of femur fracture does not matter. What matters is whether or not the patient is in pain and discomfort, and do we need to control that for the patient. And in the given situation, we can do that very effectively, very nicely, for best part of 8 hours. Thank you for watching. Stay.